Okay, we'll get started now. Welcome to the AES Professor's Rounds, Epilepsy Surgery Case Studies. My name is Jill Hunt, Education Coordinator for the AES. Before we get started, I have a few housekeeping notes. This is a 1-hour interactive session, and we encourage your participation. I will unmute your microphone so you have control. If you are not speaking, please keep your microphone muted. You can also use the chat function for questions or comments. Click on the chat icon in your control panel. A recording of this case conference will be made available on the Training Continuity section of the AES COVID-19 Resource Library. Your professor today is Dr. Chris Skidmore, Associate Professor of Neurology and Vice Chair for Clinical Affairs in the Department of Neurology at Thomas Jefferson University. Welcome, Dr. Skidmore. I believe you're muted.
Hi, everyone. My name is Chris Skidmore. It's nice to have the opportunity to interact with you. As mentioned, I want this to be interactive as much as possible, given the limitations of an online meeting. But over the next couple of weeks here, we're going to be doing, over the next couple of months, we're going to be doing some video EEG cases that highlight epilepsy surgery, but also interesting seizure semiology. And so we're going to try to make this as educational as possible for all of you. So let's talk about the first case, and we're going to split up my talk time into 3 cases today. So the first case is that of a 71-year-old right-handed female who began to have seizures at age 30. She had no known epilepsy risk factors, and she describes her seizure semiology when you see her in the office as having an auditory aura in the past, but currently doesn't have one. So in the past, she described this kind of weird buzzing sound, but currently she's not really having that too much. She then typically has loss of awareness, and there are reports of oral and manual automatisms. And the duration of the seizures lasts anywhere from a minute to a minute and a half, and she was having an average of about 1 per week. She then also had this seizure type then progress on to focal to bilateral tonic-clonic seizures about 1 to 2 times per month. And so if we just take this kind of history by itself, I guess if we think about the seizure semiology that we've obtained now in the clinic from the patient, is there any thoughts so far about localization and or lateralization for this patient? And so feel free to chime in or write in the chat box. Okay, you guys are all being shy.
We had a comment here that said lateral temporal lobe epilepsy or Herschel's gyrus.
Herschel's gyrus, yeah. So the auditory aura would suggest that this is a lateral, not a mesial onset epilepsy, but maybe a lateral temporal lobe epilepsy. And what goes along with that is the frequent bilateral tonic-clonic seizures, because lateral temporal lobe epilepsy is more of a neocortical onset and typically has rapid spread to secondary generalization or focal to bilateral tonic-clonic, as they're now called. And so, yeah, you're thinking temporal lobe, and you're thinking probably lateral somewhere near Herschel's gyrus, given the auditory aura. The oral and manual automatisms are also classically seen in temporal lobe epilepsy, but there's really nothing here to suggest whether this is right temporal lobe or left temporal lobe based on kind of what we have so far. All right, so let's move on. Great job. So she's currently on lamotrigine extended release, 200 milligrams twice a day. And oftentimes, even though the extended release preparation really is designed to be a once-a-day medication, it's not uncommon that you'll see some of us prescribe it as a twice-a-day medication because it helps further flatten out the area under the curve and reduce peak dose side effects. So it's not uncommon still to see it sometimes given as a BID drug. She's previously failed phenytoin, phenobarbital, and perampanel, again, now supporting a diagnosis of medically intractable seizures, right? Because she's failed more than 2 or 3 AEDs at appropriate dosages. She is a retired school teacher, lives with her husband, and she has a completely normal neurological exam as well as a general physical examination. And so here is her interictal EEG, and I'll just orient you to our montage. So we read right over left. So if we look below the EKG line, you have right temporal followed by left temporal, right central, left central, and some midline electrodes. And on the top half of the page, we do across the ear, basically from CZ across the right temporal, then connecting right temporal to left temporal, and then back to CZ. And so would anybody care to comment on the abnormality that is displayed on this page? So there are these broad sharp waves, phase reversing at T2 in this transverse montage here. And you can see another one here in like about the 6th second, and a more broad one here in about the 7th or 8th second. And if we look at this on the AP montage, it's phase reversing at F8. So we would classify this as an anterior temporal lobe spike or sharp wave. In this case, sharp wave, because it's broader than 80 milliseconds. So we have repetitive right anterior temporal sharp waves. And here's our seizure. So I'm going to let the whole thing play through, and then I would like for you all to comment on what are the salient features, what are the important things that would need to be documented that are going to basically lend some information with respect to localization and lateralization. And so let me go ahead and play the video.
All right. I'm not feeling well. Like seizure?
I don't know if you call nurse in. I don't know.
Don't press the button?
Yeah. Which one?
This one? I'm gonna press the button.
What are you going to do?
All right. Code word is banana.
Banana. Okay.
Huh?
It's all right.
She thinks she's having a bed.
Yeah.
All right.
I'm gonna.
Back away now.
You alright?
Mm-hmm.
Clap your hands 2 times for me. I'm gonna put your feet up. Alright?
Mm-hmm.
Good. Clap your hands 2 times for me. What color is my shirt over here?
Blue.
Good.
Mm-hmm.
Can you tell me what day it is today?
Friday.
Good. What is the year? What's the year?
2017.
Good. And you know who the president is?
Yeah.
Who? Who's the president? You know who the president is?
Mm-hmm.
Mrs. Jones?
Mm-hmm.
Who's president?
Whatever. But, it's constant. Whatever we did with our kids, he thought we could be doing the same for him, type of thing. But it worked out.
No.
Whatever.
Point up to the sky for me.
Yeah. Well, look at it.
Point up to the sky for me.
Mm-hmm.
Okay, point up to the sky for me. Put your finger and point up to the sky. So give me a big smile. Stick your tongue out. Repeat the sentence. It's a bright and sunny day.
It's a bright and sunny day.
Yes.
Good. So any thoughts about the seizure semiology? What are the salient features here?
So there was a non-forced head deviation towards the left
Okay.
for oral and bimanual automatisms. There was the rocking of the body, and I don't know if that's part of it or is just because she's in the seizure where she's feeling uncomfortable. I see that she's able to speak, but she's saying incoherent sentences, not going properly with the questions.
So do you think that the speech, did it change though throughout the seizure?
I think that I didn't manage to hear what she was saying, but I didn't feel that it wasn't an appropriate answer. I didn't know whether she understands what she's saying. But she's able to form words, but she wasn't speaking like fluently.
Okay.
Say.
Yeah, so we can take a peek at it again. So I think if we were to think about seizure semiology, I think what we want to do is think about what we're seeing in kind of a chronological order and kind of list it that way. So I think first and foremost, she has an aura, right? Because she's able to alert, that was a neuropsych technician that was in the room with her. So she's able to alert the neuropsych technician that she's having a seizure. So she's having some kind of aura. She then develops very prominent oral and manual automatisms and some rocking motion, as you correctly pointed out. But early on, she's actually talking and she's actually able to answer questions. She was able to kind of look at the nurse so that she had a non-versive head turn to the left. And as soon as the nurse asked her to look at her, she immediately turned back and said that her shirt was blue. So she was able to answer questions appropriately kind of earlier in the seizure, but then very late in the seizure, she lost the ability to respond and interact. So specifically when she kind of asked her to point to the ceiling. So there was very late this kind of more loss of awareness, but early on more this kind of preserved awareness. So let's just take a look at that again.
All right.
So here's where she'll alert the nurse, the technician.
Next seizure.
I don't know if you call the nurse in. I don't know.
Press the button.
And what she said was, I don't know, but can you call the nurse? So she is kind of speaking in more complete sentences here.
Yeah. Which one?
This one. I'm going to press the button.
What are you going to do?
All right.
And then she says, what are you going to do? And we'll move a little bit forward to when the nurse kind of comes in the room.
Back away from.
You all right? Clap your hands 2 times for me.
So I'll give you, she doesn't clap at this point, but it's not uncommon that individuals in the midst of a seizure don't necessarily follow 100% of the directions we give them because they're obviously distracted and distressed by the seizure that they're seeing.
I'm going to put your feet up. All right? Good. Clap your hands 2 times for me. What color is my shirt over here?
Blue.
Good.
So kind of in putting everything together, I would say that this started with an aura, and we'd have to kind of ask her what that aura was, whether it was an auditory aura, followed by a period of time with oral and manual automatisms with preserved awareness. And so this automatisms with preserved awareness is highly suggestive of a seizure coming from the non-dominant temporal lobe. And so since she is right-handed, we're going to assume, correct 99% of the time, that her left hemisphere is the dominant hemisphere. So that automatisms with preserved awareness would be highly suggestive, in her case, of a seizure coming from the right temporal lobe. So that's our first now kind of lateralizing and localizing sign that we clearly have. And then very late in the course, she kind of stops responding. She has a little bit more nonsense.
We do with our kids. He thought we could be doing the same for him, type of thing. But it worked out.
Mouth.
Whatever.
And so if we go back to the clinical history that they gave us, they said that she does lose awareness, and that is true. But I think, the family and the caregivers kind of missed the fact that early on she is kind of interactive and talking. And so that then became a very critical piece that we pulled out from the video to be highly suggestive of a right temporal lobe onset. And then I suspect later on in the disease, as it's spreading perhaps to other regions, including to the opposite hemisphere, that's when she's losing awareness. Any questions about the seizure semiology? Any questions in the chat, Jill?
No questions in the chat for that.
Okay, all right, so let's move on then. And so this is the ictal EEG that corresponded with that video that you just saw. And again, it's the same montage that I showed you previously. Again, we read right over left. So you have your transverse chain and your AP chains below the EKG line. And if we look, the first change that we see probably starts with some increased rhythmicity, kind of very lower amplitude rhythmic delta that starts to come in here. A little hard, not definitive, but you can certainly see that. You see a little bit on the AP chain here, but it's really not until you get to the next page that you see this very high amplitude rhythmic theta delta that kind of comes in. That's most pronounced over the right temporal region. But if you notice, we also see it in the left temporal region. And it's not uncommon in temporal lobe seizures that you will see the seizure discharge in both temporal lobes. It's just that it often becomes more prominent or pronounced in one temporal lobe. And so as we follow this along, the ictal discharge remains more prominent. And that's the value of this transverse montage, is it shows you that the majority of that ictal discharge is actually coming from the right hemisphere. I'm going to go to the next page. You can see it here, it speeds up even faster, right? So we've met what is classically talked about as Risinger criteria from a paper that was back in the kind of, I think, the late 90s about reaching a rhythmic theta discharge being classic for temporal lobe epilepsy, typically mesial temporal lobe epilepsy, but classic for temporal lobe epilepsy. And so you can see that discharge here, and you can see that the rhythmic discharge is much better formed in the right temporal region, even on the AP, than it is in the left. In the left, you have this kind of lower amplitude, semi-rhythmic delta that's kind of there. We'll go to the next page. And I think there's one more page. And now you're starting to see it peter out. And as it's kind of petering out, you can, again, still see it bilaterally. And then here is the seizure end. And so the onset, we felt, was consistent with right temporal, certainly with spread to the left temporal region. And so now we have interictal EEG, we have ictal EEG, as well as seizure semiology, all pointing to the right temporal region. Any questions about the ictal EEG? Okay, we're going to go ahead and move forward then. And here's her MRI. And so if we look at her MRI, I'm showing you axial flare in the top panel, and I'm sorry, axial flare image here, and I'll show you a coronal T2 in a moment. Would anybody care to comment on the findings on this MRI? Okay, so we have in the white matter, cerebral white matter, we have obviously some increased T2 signal abnormalities, some in the periphery, some a little bit closer to the ventricle, but in this kind of rather non-specific fashion, consistent most likely with microangiopathic disease. And there's a hint that here, maybe the mesial temporal lobe on the right side is a little bit brighter, and perhaps maybe you see the temporal horn a little bit better compared to the left, although this is going to be better visualized on a coronal image. So let's take a look at that coronal image. Now we have coronal T2. We'll give everyone a second to kind of look over this and make your own opinion. And so again, if we first focus on the kind of white matter lesions, we see these rather non-specific or kind of white matter lesions kind of throughout her cortex. And then if we focus in on the temporal lobes, and so first of all, I always like to kind of first look at the volume just overall of the temporal lobes and see if you think there's a discrepancy between the right and left with respect to total volume. And I don't think there's any appreciable significant difference in total volume of the temporal lobe between right and left. I think if we follow this back, we see the amygdala here, and now we're starting to see the hippocampus here with a little bit of digitations. But here's the first clue that maybe there's some increased signal in the hippocampus on the right compared to the left. And on the next image, again, now definitely more increased signal in that right hippocampus compared to the left. And so even back as far as the tail, also still seeing some increased signal in that hippocampus on the right compared to the left. And so the imaging findings certainly now on the coronal would be consistent with right mesial temporal sclerosis or hippocampal sclerosis. So we did find the right MTS and with a little bit of hippocampal atrophy as well. She had, on an FDG PET scan, she had right temporal hypometabolism. And on neuropsychological testing, she had low average verbal memory. So what's everyone's thoughts? How would you approach this from a surgical perspective? Does she qualify for surgery? And if so, what surgery would you recommend?
How do we explain the auditory aura?
It is hard, right? So I think that is a little bit discordant in this case. The fact that she reported an auditory aura in the past and she had mesial temporal sclerosis. So that's a good point. Do we have to worry about that auditory aura? Is that a red flag? And I would say yes, that an auditory aura is a red flag. We will occasionally see auditory auras even in mesial temporal cases, and I think it just reflects a spread of the ictal discharge out there. But I do think that's a red flag. So what's the other red flag for this individual with temporal lobe epilepsy based on her history? The fact that she's having very frequent focal to bilateral tonic-clonic seizures has been shown to be an independent negative factor for seizure outcome after epilepsy surgery with temporal lobe epilepsy. So the fact that she's also having those bilateral tonic-clonic seizures would imply that perhaps she will not respond to a traditional temporal lobectomy, as well as somebody who does not have a history of just without generalized tonic-clonic seizures. So those to me are the two kind of red flags in her case, is the auditory aura and the focal to bilateral tonic-clonic seizures. So what are some, does that mean she's not a candidate, or I guess how would you want to approach that?
We've had some chat comments here. One
Sure.
said ATL on right side, and another
Okay.
said right standard temporal lobectomy.
Okay.
Implantation would be a good option.
Okay. And so what would your, if you wanted to, so we have an option of, do we just go with a standard temporal lobectomy? And remember that we're assuming this is her non-dominant temporal lobe. And so a standard temporal lobectomy in a non-dominant temporal lobe, you're talking about 5 centimeters of lateral cortex being removed plus all of the mesial structures versus an implant. So I guess if you wanted to implant, where would you implant and why would you want to implant it?
So I will implant the medial aspect of the right temporal lobe and the lateral aspect as well, just to see where does it really start.
Okay. So we can maybe focus some electrodes, obviously in the, and typically when we talk about mesial, we'll probably have an electrode in the amygdala, a few in the hippocampus, maybe the anterior, middle, and posterior aspect of the hippocampus. And then we can probably focus some electrodes around that lateral temporal neocortex, near Heschel's gyrus, to kind of understand, is this really a lateral temporal lobe epilepsy? And maybe there's a cortical dysplasia or something else that we're missing on the MRI. Or is this really a mesial temporal lobe epilepsy that's for some reason rapidly spreading out to the lateral neocortex? Good. So I think you could approach this in either way. You know, the other option when we talk about temporal lobe epilepsy these days is laser ablation. So, you know, laser ablation of the mesial structures in mesial temporal sclerosis is now becoming fairly common. There's an ongoing national trial to determine kind of how truly effective it is. It's called the SLATE trial. But in her case, because of the auditory aura and the frequent bilateral tonic-clonic seizures, I would lean against doing a minimally invasive surgery and, you know, either offer a large right temporal lobectomy or go with an implant. So there's 2 ways you can approach that. One is, you know, you're going to definitely do a temporal lobectomy. And so you can try to do the maximum temporal lobectomy that you can, and then see how she responds to that, and always go back in and do an implant at a later date if you think you're going to need to do something more than a temporal lobectomy. Or you can do your intracranial implant up front. And so I think some of that kind of takes into account your patient. And so, you know, with our individual patient, she's 71 years old, so she's certainly on the older side for epilepsy surgery, not the oldest person we've ever operated on, but on the older side. She has relatively low comorbid risk, but we know that sitting around with an intracranial implant in could predispose her for complications in the hospital, including clots and so forth. So you could make the argument in her case to do a large anatomic temporal lobectomy, taking as much of the lateral cortex as the surgeon feels comfortable, and then proceeding after that with a intracranial implant if they fail, you know, 6 months, a year from now. So you could argue either way, and I've seen centers do both ways. So, but those are the two options that you have to think about, and then weigh in the patient's risk factors.
Chris, what about doing laser ablation at first, and then if she fails, going to implant? Then you don't take the risk of having a prolonged admission. You do the minimally invasive, you give her a chance for a cure, and then if it doesn't work, then you go for implants.
Yeah, my concern, Lilak, with doing just the laser ablation in this person that we already know has red flags is then you're going to have to make, then you're either doing 2 or 3 surgeries as opposed to just doing 1 or 2. So I'm concerned enough about the red flags, and given her age, I would want to try to be a little bit more aggressive early on.
Okay.
Certainly an option, but I think the red flags really push me away from doing laser ablation in this specific patient. Any other questions about this case before we move on to case number 2? All right, so some great discussion around that.
Just before we go, are there any EEG indicators of whether you feel it's more mesial than neocortical? What helps you the most in the EEG?
So the Reisinger criteria that's described, right, reaching theta frequency within 30 seconds of onset has been described. That is a more classical mesial pattern. Certainly polyspikes, paroxysmal fast is going to be more consistent with the neocortical onset epilepsy. And so you might see that. So, you know, the typical mesial onset is going to be, you know, rhythmic theta delta in the very beginning, kind of certainly speeding up to about rhythmic theta discharge, and then either spreading to the opposite side or remaining restricted, and then may lead to secondary generalization, but typically late. Whereas neocortical epilepsy, you often might see either polyspikes or paroxysmal fast at onset because it's neocortical onset, and then rapid secondary generalization, usually within about 30 to 45 per second. So usually lateral temporal lobe epilepsy, they go on to focal to bilateral tonic-clonic seizures, usually around 60 seconds or less. So those are the things that can help you.
Thank you.
Yeah. All right, so case 2. So now opposite end of the age spectrum, now we're going to go to a 29-year-old male, had seizure onset at age 10. Again, no known epilepsy risk factors. And he describes these very focal motor seizures without impairment of awareness, where he gets right lower face and hand clonic activity. The seizure itself, the clonic activity, only lasts for about 15 to 45 seconds. So the seizure itself is not very disabling. But the problem is, during that postictal period, he develops a paresis and an incoordination specifically of his hand that lasts for hours. And when I met him, he was actually going to school to try to become a kind of like a sports medicine technician. So somebody that would kind of wrap athletes, you know, knees or ankles and things like that. And so he required his hands in his chosen profession that he was eventually planning on doing. And he was having them very frequently. So now, again, it's only a 15-second seizure, but he's having anywhere from 15 to 20 per day. And then if you factor in the incoordination, you know, really he's having major disability from this focal aware seizure for significant portions of the day. And he finds that the more he uses his hand, in this case the right hand, it tends to trigger or bring out the seizures. When I met him, he was on oxcarbazepine, and as you can see, he failed numerous other antiepileptic drugs. As I mentioned, he was a college student living with roommates. When I examined him in the office, he actually had on exam a right central seventh, and he had some mild weakness and incoordination of the right hand. So just some very subtle weakness of the hand, and some incoordination of that hand as well. And so if we take the history and we take the physical examination, again, can we start to think about lateralization and localization just based on this information alone? Does anybody want to chime in?
Left premotor.
Okay. Left premotor. Why premotor as opposed to left motor?
Sorry, I meant actually motor.
Okay. I think it could be either. It could be either. I don't think you can very easily differentiate between premotor and motor. So I think it could be either, right? But yeah, so we're thinking kind of left perirolandic cortex. He hasn't told us anything about a sensory aura, but we might want to quiz him about the sensory aura to see if there's any subtle sensory signs just preceding the onset of the motor activity. As you can imagine, the patients focus on the positive motor activity and often ignore or minimize the sensory symptoms. So you could always ask in more detail, and he denied sensory symptoms prior to onset, but I'm thinking left perirolandic cortex. I'm thinking it's got to be pretty close to the motor cortex, because it's not like this is a discharge that's spreading to the motor cortex and then rapidly secondary generalizing and causing loss of awareness with bilateral tonic-clonic seizures. And so it's probably right in that perirolandic cortex region. Good. And so this was his interictal EEG. And again, right central, left central, and then some transverse electrodes across the frontal electrodes, across the central electrodes, and across the parietal electrodes. And what we felt that we found consistently over time is this little tiny spike here at C3. Here's just another example of that to prove that we weren't hallucinating. But it really took a long time staring at this EEG to kind of find these little spikes that were present in his EEG. And you can see this reflected down here at C3 as well. And then as ictal EEG, we saw what appeared to be a little bit of paroxysmal fast that kind of started here in a similar location. So this little bit of fast activity, kind of beta frequency that you can see speeds up a little bit, and then it basically gets obscured by muscle artifact and movement artifact. It's impossible to kind of read the EEG through this. And then eventually afterwards, there did appear to be maybe a touch of some focal slowing in this location as well. I'm going to go back and look at that again. So again, what we're talking about is this kind of paroxysmal fast at onset here. And again, you can see this is seizure number 4. So we were looking at numerous seizures, right? The frontal lobe epilepsies, especially with motor, and once it gets obscured, are very, very challenging to review on EEG. So it's always good to get numerous seizures to really build your confidence around this. And I can tell you that we captured enough seizures to build our confidence that yes, this we did feel was an ictal discharge that we saw in the left frontal central region that we were not seeing in the right. And here's his MRI. So I'll give you guys a second to look at that. So in the top panel, flare axial images, and in the bottom, T2 sagittal images. And so what we noticed was this increased T2 signal. So if this is central sulcus right here, so there's this increased T2 signal in the primary motor cortex. You can see on multiple slices. And that corresponds to this gyrus here, which in addition to having the increased signal also looks a little bit malformed. It doesn't look like what we would expect of the typical kind of gyrus in this location. So we thought there was a little bit of blurring of the gray white matter junction and some increased T2 signal. And we felt that this was consistent with a cortical dysplasia. And when you see increased flare signal, T2 signal, with a dysplasia, that highly suggestive of the fact when you look at it under pathology that there will be balloon cells, so a type 2B dysplasia. And so we felt like we had semiology now, we had ictal EEG, interictal EEG, and now imaging evidence of a left motor cortex semiology. And so the question is, what would you do with this patient? Is this person a candidate for surgery? Are they not a candidate for surgery? What should we proceed? Should I just continue with 10 more drug trials? What do you all think?
If there's no, we need to make sure that the patient is not going to lose function if we decide to remove this questionable focal cortical dysplasia.
Yep.
It depends on the function, that like losing function or not losing function.
Okay, so certainly, right, we want to, part of what we're doing in epilepsy surgery is trying to improve an individual's quality of life. And if we make him hemiparetic, that's probably going to be a very negative outcome, right? So yes, we need to take that into consideration. Absolutely. Good.
We had a chat comment said, not a candidate for surgery because it is an eloquent area. Try neurostimulation.
Okay. So not a candidate for resective surgery because it is an eloquent cortical region. And so, okay. And that is true for many of the cases. Now, it really depends on where in the motor cortex you're thinking about operating. If it's in just the face cortex, you probably can get away with operating on the face, tolerate a little bit of a facial droop, and still have a very good functional and quality of life outcome. I agree with you. If it's hand, in a dominant hand, certainly, and if it is leg, we would almost never resect in those locations because, again, it has a very negative functional outcome. So neurostimulation is certainly an option. We have 3 neurostimulators available in the United States. We could do vagus nerve stimulator, we could do the deep brain stimulator, or we can do responsive neurostimulation. So I think all of those are very good options. I will tell you that when we discussed this case, it was back in 2010, so it predated RNS and DBS. And so we only had VNS as an option. And so we elected to actually implant him because what we wanted to understand was, you know, we know that what you see on the MRI scan with the dysplasia is typically the tip of the iceberg. And could it be possible that while we saw the dysplasia sitting in the motor cortex, maybe the onset, the dysplasia extends beyond that, and maybe the onset actually was in premotor and spreading in. So we really wanted to be certain before we said that he had no surgical options. And so at that time, back in 2010, we implanted a grid over the periorbital cortex with some strip electrodes in front of, below, and behind. And we mapped out motor function. And so all of the yellow electrodes are where motor function is, and all the hashed ones are where seizure onset was. And so his cortex was organized rather normally, meaning we found eyes and face where we expected to find it. Hand was kind of up in this region. And so let me kind of just show you what the EEG looked like. And so on an interictal EEG, we saw interictal fast activity that came in around LFG 30, 31, 37, 38, 44, 45. We saw some focal spikes in that same distribution. We saw other spikes, though, that were also a little bit more broad and kind of simultaneous across that region. So some that were more isolated, in this case to, let's say, electrode number 30, but other ones that were more simultaneous across all of those electrodes. And so if we go back to the map, you know, 30, 31, 37, 38, 40, 45 are kind of all in this region here, right in that motor cortex where we expect it, in mostly the hand region. And then if we looked at ictal EEG, it started with that fast activity in those same contacts, spread to gamma activity. You see here, here, and here, and then eventually slowed down to more of a theta discharge. And so now we had interictal and ictal EEG pointing to the upper part of this grid, unfortunately exactly co-localizing with motor hand cortex. So it wasn't premotor, we thought it was motor hand cortex. And so, yes, we agreed with you. We could not do a resection, especially given his pathway for chosen profession. And so at the time, we decided to do multiple subpial transections, which is a operative surgical procedure, not done a ton these days because now we have more neurostimulator options, but it is an option when the surgeon may need to operate in eloquent cortex, motor language cortex. And what you're trying to do is the surgeon creates a checkerboard pattern that's kind of perpendicular to the cortex to try to remove the horizontal spread of the seizure discharge, but preserving the deep spread, which is actually the axons leaving that controls motor function. And so we did a multiple subfield transection of that entire motor cortical region. He had a transient reduction in seizures, but unfortunately his seizures basically came back to baseline, so it did not work for him. We then tried other options, including oxcarbazepine extended release, because he would have side effects if I tried to push the dose too high, and the side effects would get better with the extended release. When perampanel came out, we tried that. When clobazam came out, we tried that. When the lacosamide came out, we tried that. So we tried a whole host of different options. He completed college, but literally couldn't work because every time he went to use his hand, he would have seizures. And so ultimately, once RNS was approved, he had a RNS implant in 2015. He has maintained a greater than 50% reduction in seizures overall. But more importantly for him, it's decreased the overall intensity of his seizures and reduced the postictal period to the point that now he's actually working and working in this kind of sports medicine field. And so you can see here the RNS electrode that's implanted into the cortex. Sorry, somebody's calling me. And you can see these two strip electrodes that basically we placed using intraoperative motor mapping to place immediately over that cortical hand region. Any questions about this case?
Yes, I have a question.
Yep.
If you had to do the intracranial EEG today, would you do it with SEEG, or you still think that there is an advantage for grid to do like this kind of mapping?
Yeah, so I mean, obviously SEEG is becoming the preferred technique for most intracranial implants in the United States. It already has been in Europe for a long time. There is a theoretical advantage to a grid like this if you're trying to do motor mapping, because you can get these very, very beautiful, detailed, very precise map of the motor homunculus and the sensory cortex. That is harder to do with SEEG electrodes. However, we have placed numerous SEEG electrodes in what we would call a pseudo-grid fashion. So in other words, if we thought this was motor cortex, we might place a series of electrodes along the motor cortex to try to get a little bit denser allotment of electrodes to allow us to do the cortical surface mapping without having to do an entire craniotomy. So there are some, for mapping purposes, advantages to a craniotomy with grids. But often we're trying to do all that with SEEG, and then if we need to, we're doing detailed motor mapping in the OR at the time of the actual resection. That answer your question?
Yes.
Okay.
So you would do SEEG today?
Today we'd probably do SEEG. The morbidity and complication rate with stereo EEG is so dramatically reduced compared to a craniotomy. So with a craniotomy, you really are ideally implanting somebody and getting them explanted, certainly within less than 2 weeks, ideally within a week. Otherwise, the potential complication rate goes up, including infection risk. With SEEG, you can now leave electrodes in for weeks, and as you know, Lilach, we've had people with electrodes in for months in the hospital. And so it is a much better tolerated procedure, much safer procedure. All right, let's move on to the last case. The last case is a 22-year-old right-handed male, had seizure onset at age 19, so a couple years prior to this visit. And his risk factors included delay language onset until about 2.5 years of age. And he required special education classes initially in school. But by the end of the time in high school, he was mainstreamed at that point and taking normal classes. His seizure semiology, he described no warning, but did have loss of awareness. He would kind of clear his throat and then repetitively say over and over again, "We are good, we are good, we are good," while kind of gesturing with his hands. And in the past, he used a different phrase that would be what you need, what you need, what you need. He'd say it over and over again. And I'm going to show you what this looks like in a moment. The typical seizure duration was about 15 seconds or less. But the problem was he would have anywhere from 0 to 10 per day, 5 days per week, right? So he's having multiple seizures, multiple days per week, many of them coming from sleep, but not all. And let me just kind of, and we'll talk about the rest of the history and then I'll show you the video. He currently was on levetiracetam, previously had failed zonisamide, so he's medically intractable. He was a high school graduate working full-time doing building maintenance and lived with his parents still. And overall, we thought his physical examination was unremarkable with maybe some slight reduction in fundamental knowledge and some slight reduction in math skills. And so here's his interictal EEG, and you can see this burst of paroxysmal fast activity that really is generalized, this paroxysmal fast and polyspikes that are kind of generalized across all of the electrodes. He had some that were just more restricted sharp waves, again, that are maximum kind of bifrontally. And here's his video.
Nice, thanks. This is the new HTC One M8 Pro Windows. Sleek, but I wouldn't just a pretty face. Too, I could check your calendar. That's perfect to help you get your man petty on time.
We're good! We're good! We're good!
All right. It's okay. It's okay.
We're good! 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 We're good!
Code word's banana.
And that's the end of the seizure.
Can you clap your hands 3 times? Clap your hands. Good. Can you touch your nose with your right hand? With your right hand? Good. What color is your shirt?
Good. So anybody want to kind of comment so far? What do we think about the semiology?
Rising from sleep very frequently and this hyperkinetic movement, that all points to frontal lobe.
Okay, so nocturnal onset, very rapid with these large proximal movements and kind of this kind of rocking and kind of repetitive kind of vocalizations. The other thing that goes along with it is very brief, about 15 seconds, and then very rapid return to normal. Does somebody else have a comment?
We had a comment in chat that said mesial-frontal lobe epilepsy.
Okay, so mesial-frontal lobe onset, good. So we're all kind of thinking the same thing, and it kind of goes along with the EEG, right? So this EEG could be, is this really generalized polyspikes or generalized paroxysmal fast? Or is this bilateral secondary hypersynchrony? So is it starting and spreading across the corpus callosum from one frontal lobe to the next so quickly that it looks like it's generalized? And so that's something that we have to kind of keep in the back of our minds. And then when we look at that ictal EEG, so you can see that he's asleep, but he's already having these repetitive epileptiform discharges. And then at the seizure onset, he has this basically attenuation of frequencies, right? This hypersynchronization, right? So when you have a hypersynchronization of EEG, because our amplifiers throw out what's in common, when you have this hypersynchronization, you get this flattening of the EEG, followed by this very fast discharge that really you cannot localize to one particular region or location, and then obscured by muscle artifact. And so the question becomes, based on this, is this focal epilepsy? Is this generalized epilepsy? Well, this doesn't look like idiopathic generalized epilepsy. It doesn't look like the semiology associated with idiopathic generalized epilepsy. The semiology looks more like that of a focal epilepsy. And so this is an example where if you just looked at the EEG, you might fool yourself and think that this person has an idiopathic generalized epilepsy, but you really need to look at the seizure semiology to kind of help force you to really focus on focal epilepsy. And so here's his MRI, and I'll give you a second to look at this and stare at it like we did for probably an hour to wonder about anything. And what we saw was in this superior frontal gyrus at the very top here, we thought there was a blurring of the gray-white junction. So if you compare this to the homologous region on the other side, you can see that the white matter arborization is very easy to see, and here you lose it, and you lose it here as well. And it was consistent across multiple slices. So we thought that there was some blurring of the gray-white junction in this superior mesial frontal gyrus. And here's his PET scan. And the PET scan showed hypometabolism in that exact same location. So you can see there's focal hypometabolism here compared to the homologous region on the other side. And so with that gray-white matter blurring and this focal hypometabolism, now what do we think about the case? Is this somebody that is this a frontal lobe epilepsy? If it is, what do you think the pathology is, and are there surgical options for him?
The chat comments say it could be FCD.
So it could be a focal cortical dysplasia, absolutely correct. And what tells you that is that blurring of that gray-white junction. So great, I agree with that. And does anybody want to operate on him, or we're going to just continue doing more medications?
That a candidate for resective surgery.
Okay. So it's left frontal pole. He's right-handed, so we're suspecting that this is dominant hemisphere, but this is well anterior to left frontal pole. So we agreed, right? We thought, you know, this is a very severe seizure. He's having very frequent seizures. And so, again, this was just prior to us going to SEEG. So we did a small grid over the periorlandic cortex because we wanted to be able to map out motor cortex in case we planned on doing a large premotor frontal resection, right? So that's why we put this grid here, was to basically map out motor cortex. And then we did a whole series of strip electrodes, some covering temporal just to be certain, some going interhemispheric, some going anterior into the frontal pole, and some going a little bit more posterior. And this is just a blown up view of that. What we found was seizure onset here in that region of the focal cortical dysplasia, and it was focal cortical dysplasia on pathology. In that region of hypometabolism, we found seizure onset in these electrodes here. And so the surgeons were able to go in and do a very restricted resection based on the subdural grids and strips that we had. And I'm happy to report that now he's been seizure-free. Actually, now this is old. He's been seizure-free for over 2 years now. And so we did this anterior superior left frontal resection. While we were there, again, because frontal lobe epilepsy can be sometimes very difficult to nail down and be sure that you've resected the entire thing, the surgeons also did an anterior 2/3 corpus callosotomy. And so the thought was that we know that he's at risk for that bilateral hypersynchrony. And so we basically we did the focal resection and we did the callosotomy to basically cover in case we missed the focal onset, to certainly hopefully minimize the severity of the seizures as well. So we did both of those surgeries at the same time. He came out without any motor or cognitive deficits, and now it's been seizure-free. So I want to thank you for your time over the last hour. I tried to give you a couple of different cases that can be approached in different ways, and just appreciate the opportunity to kind of discuss these with you. Are there any questions about this case or any of the other cases before we end? All right, if that's the case, well, thank you very much for your attention today. I hope you all stay well, and hopefully I'll look forward to seeing you all. I think we're doing this next month and the month after that as well on Thursday at 1 o'clock. So thanks, have a great day.